Hi,
Hello,
Barry.
good afternoon. Hi, Sean.
Hi.
Good afternoon. I'm here with Adam Geronemus to the right, one of my partners, our partners, and Andy Hall is one of our fellows. In the interim, we've kind of had an emergency here in another room, and it's pulled a fellow who actually is familiar with this patient out. So I'm going to go ahead and make the presentation if we could have the slides. So this is a patient that we've seen who's had a chief complaint of bilateral claudic and lower extremity pain. He's been a bit of a diagnostic dilemma because he's known to have spinal stenosis and has had MRI demonstrating herniated discs, and he's represented a little bit of a diagnostic conundrum in terms of the trying to differentiate vasculogenic from neurogenic claudication. Let's see the first slide. These are our disclosures. Next. He develops this symptom after about 1 minute of walking, has no symptoms of rest discomfort, no pain at night, and he has a definite history of spinal stenosis, however. Next. And he's had spinal surgery as well. He has a history of certain cardiovascular risk factors, including hypertension, COPD, low back pain. He's had a hernia repair, lumbar spine surgery, as I mentioned, at L4-5. And S1 dating back to 2009. He's currently on the medications that you see there. He's a prior smoker, a heavy smoker who quit some time ago. Next. Physical examination revealed left common femoral artery pulses that were palpable but weak, and left dorsalis pedis palpable 1+ pulses on the right. The common femoral artery, actually to my exam, was minimally palpable, and then he had only Doppler signals to the lower extremity. Next. These pulse volume recording waveforms are significant, and if you look, there's sort of a systematic reduction in amplitude and qualitative configuration throughout. The ankle brachial indices are, I think, deceptively high at 0.79. They do deteriorate, however, on exercise, you can see, along with waveforms. He did develop symptoms on ambulation on the treadmill. Next. That were relieved by rest. His right external iliac artery was documented to be occluded by duplex, as you can see, and his right common femoral artery was monophasic. Next. And he underwent CT angiography that demonstrates several findings. One is obviously the occlusion of the right external iliac artery. He has mixed calcific and non-calcific plaque, as you can see. And you can also see a sense that the left common iliac artery is diseased near the ostium. Also, his left external iliac artery looks small, as does his left common femoral artery.